my name is Mary Sellars, and this is my case study report for Case Connections Unit 4 in my medical biochemistry course. So I'm going to start with case 1, which is the case study is as follows. A newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. The first question is, which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation, blood glucose, urinary acids, serum fatty acids, or plasma glutamine? And additionally, a full blood workup was ordered for this female, and the data is presented below. The initial blood ammonia level was elevated at 314 micrograms per deciliter, much higher than that normal range from 17 to 80, obviously. And later rose to over 600, which is, 600 times the normal range. The urine orotic acid level was markedly elevated at 473, and the plasma citrulline level was normal. In this patient where orotic acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. So in my opinion, the best diagnostic test to order for this patient would be plasma glutamine in order to distinguish if the root cause of this disorder is caused by deficiency in the urea cycle or in the beta oxidation mechanisms. Glutamine is a key amino acid for many bodily processes, especially as a non-toxic nitrogen carrier in protein turnover in the urea cycle. A plasma glutamine panel would uncover whether the disorder is related to deficiencies related to the urea cycle in this patient, as elevated blood ammonia would rise, so would plasma glutamine. And if plasma glutamine is normal, then we would be able to rule out urea cycle disorders. If the disorder was related to processes in beta oxidation, then plasma glutamine would not be elevated. They would be normal, which would allow us to rule out the urea cycle as a root cause of the patient's symptoms and order more diagnostic tests later on. I don't know much about how the ease of running these specific tests, so obviously an attending physician would make the call. Serum fatty acids, urinary acids, and blood glucose, I think, are more inefficient compared to plasma glutamine for the diagnosis of this type and the patient's symptoms that we're seeing presented in this case. The urea cycle enzyme that this patient is most likely deficient in is the ornithine transcarbamylase, OTC, as evidenced by the patient's elevated orotic acid levels. OTC is an enzyme involved in the urea cycle, which is responsible for catalyzing the reaction, which condenses carbamoyl phosphate to form citrulline, which is then shuttled out of the mitochondria. So it's a mitochondrial disorder, very common in X-linked genes, or not common, but a type of mutation that we see in X-linked genes. When a person is OTC deficient, carbamoyl phosphate accumulates within the mitochondria. It is not able to be shuttled out, resulting in the carbamoyl phosphate leaking into the cytoplasm of the cell. Increased levels of carbamoyl phosphate in the intracellular fluid will cause it to engage, the carbamoyl phosphate to engage in pyrimidine synthesis with aspirate transcarbamylase, which leads to increased levels of orotic acid in the urine of the infant infected with this disorder. This medical diagnosis is known as OTC deficiency and is an X-linked recessive genetic disorder characterized by the symptoms we have seen presented in this newborn female. The enzyme least likely to be impaired by these presenting symptoms would be carbamoyl phosphate synthase 1, CPS1. CPS1 is the least likely because it appears upstream of this biochemical pathway within the urea cycle, and the patient would appear with much different symptoms if that was the deficient enzyme. The next case I'm going to talk about is case 3. So it states as follows. A 47-year-old man presents with severe pain in his right big toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urine analysis was performed. The results from this individual is listed below. So he has elevated plasma urate and elevated or very low urinary uric acid. After further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. He tells you that he drinks between 4 and 5 liters of soda a day. The primary sugar in most soda is fructose or high fructose corn syrup. What is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. 1, overproduction of purines. 2, decreased salvage of purines. 3, decreased urinary excretion of uric acid. And then also, what is the potential impacts of this dietary modification on the presentation of gout? So gout is a very common form of arthritis caused by excessive uric acid in a patient's bloodstream, and often presents as pain in the joint of the base of the big toe and is very common in middle-aged men. The best explanation for the presentation of gout in this patient is decreased urinary excretion of uric acid. So those below average uric acid levels in his urine. Since we know this patient is a chronic and frequent consumer of fructose syrup and sugar, we can look deeper at the biochemical pathway this diet would follow. Fructose syrup is processed in the body as fructose, which is converted to purine, and then finally uric acid. So dietary fructose will form more uric acid as a result. Uric acid can then accumulate within the body, which is the root cause of this gout diagnosis. Gout causes uric acid crystals to form within the joints of the body, leading to a decrease in the urinary excretion of uric acid. So there are deposits throughout the body, and those are not making their way into the urea cycle that allows urea to be converted to urine and then be deposited by the kidneys. While more purines are being produced in this individual because of the diet, this is not the additional information that would allow us to address the root cause of the patient's symptoms. Decreased salvage of purines is also not the root cause of this individual's symptoms. The potential impact of increased high levels of dietary fructose from fructose syrup on the presentation of gout in this patient would be perhaps maybe slightly less uric acid buildup within the body, perhaps slightly higher uric acid in his urine, but natural sugar is less harmful than sugars that come from a processed source or an artificial sugar. But this patient should avoid drinks sweetened with fructose, natural or not, altogether, especially after this diagnosis, and should stick to water or other unsweetened beverages as a drink. It is also advised in patients with gout to avoid other foods that are high in purines, such as red meats and seafood. Yeah. Thank you very much.